Thank you, Hani. Okay, have we got Q&A quickly, or we ought to do it? So, Hani, may I ask you the effect of renal impairment on BMP? Because you're kind of telling everybody we should go away and do a BMP, but so our patients have impaired renal function.
So this is it's a very good point. So the acute renal impairment actually causes the BNP to increase, but this is why we use this specific cutoff point. So this specific cutoff point was discriminatory regardless of the level of GFR and regardless of the level of albuminuria. So using this specific number in the outpatient clinic from multiple studies, in fact, this was derived from the CANVAS and DECLARE studies as well, which had a significant component of patients with renal insufficiency. The CANVAS-R, as you know, was a renal study. So they utilized this cutoff point, and it seems to hold true quite well. In the acute heart failure literature, it's a little bit different. When acute heart failure, the literature, it's a little bit more murky. And when we're talking about patients who come to the emergency room, a slightly higher cutoff point is recommended, which is age dependent. So thank you for bringing that up. But in the general outpatient diabetes clinic, this is a very powerful and effective screening tool, if you would.
Can I ask a question to the panel, anybody on the panel, basically? In Ramadan, there's a disruption totally of the circadian rhythm, particularly with the sleep pattern, particularly in this part of the world. Do the negative effects of the sleep circadian rhythm or the sleep pattern counteract the beneficial effects of intermittent fasting? Anybody on the panel?
You know, I can take this. First of all, very good question. And disruption of circadian pattern has two major problems. One of them is increase in ghrelin hormone, which is hunger hormone, and also reduction in leptin, which is a satiety hormone. And actually, this also disrupts the leptin circadian pattern. Leptin circadian pattern is from 8 p.m. till 8 a.m., which means the disruption of sleep can have an impact on the hunger. So in reality, you're absolutely right. During Ramadan and with disruption of sleep pattern, you will have more hunger and more consumption of food and also the satiety.
Thank you. Ali?
Yeah, thank you very much. Ali Mamari from Oman. My question to Dr. Hani Sabur, now Pro-MB, this is something new to us. So do you suggest that when they come to our clinic also we check the Pro-MB as part of our regular work to detect this and detectable heart failure?
Thank you very much. So this was actually the subject of fairly extensive discussions when we were doing the UAE cardiometabolic guidelines, but we did refer to the ADA document, and that is actually the recommendation. Annual NT-proBNP screening with an ECG at a minimum for cardiovascular risk detection. And here the idea is to try and optimize the preventive therapy. So, you know, the ADA guideline is very clear when you should use an SGLT2 inhibitor, but most non-cardiologists find it very difficult to detect heart failure. And as you saw, about a third of the patients at Imperial Diabetes Center had subclinical heart failure that nobody knew about. So using that strategy, we feel that it will give more power to the physicians to look, you need an SGLT2 inhibitor, you need to be on an ACE or ARB, and if you use it complementarily, there's other things we recommended also, microalbumin, you really will get about 90 to 95% of patients on the right therapy for the right reasons.
We do microalbumin, but this is something
This is additional,
new,
yes. And it's fully endorsed by the ADA, and Dr. Hassanin can also add.
If I can make a comment, specifically this is important for our community because of the very significant sedentary lifestyle. True. So it's difficult to detect undiagnosed cardiac problems by virtue of physical activity where they would express chest tightness, chest pain, or shortness of breath, or peripheral arterial disease. Obviously, this doesn't it's not the same scenario in other people where they're pretty active, and that obviously then you can use your discretion on whether this is automatically required on an annual basis or not.
Okay, thank you.
Dr. Inas has a question. Go ahead, Dr. Inas.
Yeah, thank you very much for this discussion. I want to ask a question for Dr. Osama Hamdi. So I'm pleased to see you here in Zoom. And my question, thank you for this very ambitious trial. But my question, how to explain this remission isn't linked to the weight loss or the intermittent fasting during to Ramadan, and then the main question: are you if you are really sure that this remission of diabetes will be continued after the stopping of this diet reduction, because we know in the majority of cases and of medications, even with GLP-1 agonist receptor, when we stop medication and when we stop diet restriction, we have this relapse of diabetes. So here, this is a very short, I think, a very short trial. It's about one year with a restriction in diet, in calories, and then during 9 months there is a restriction. And what do you think after stopping this intervention? Are you optimistic to have the same results with this remission with diabetes? Really, I'm not sure, but what do you think about this?
Yeah, thank you, Anas. It is a very, very good question. And I will also take this opportunity to thank everyone. The quality of the lectures are amazing. And thanks, Muhammad, for getting all these stars in one room for that discussion. Yes, GROW program is a new program, new idea. But let me explain what is our prediction. You know, we have almost 1.5 years now, and we still have 80% remission. But two things we have to understand very well. During intermittent fasting, intrahepatic fat goes significantly down. And this improves insulin sensitivity to a great extent. That's number one. Number two, when you still have beta cell reserve, there is now some early studies showing that actually beta cells are not dysfunctioning or dying. Beta cells are in transformation to progenitor cells and take the fate of alpha cell. So when you improve insulin sensitivity and you reduce blood glucose level and you relieve glucose toxicity and lipotoxicity, alpha cells became progenitor cells and back to be beta cells again. So beta cells in dynamic transformation based on lipotoxicity and glucose toxicity. So if you have that period, which is not short period, it's 12 weeks of very low calorie diet and with good restriction, you will have marked improvement in insulin sensitivity and marked improvement in beta cell function. Adding to that, strength exercise will keep energy expenditure at higher level. As you had seen, there is increase in the muscle mass to fat mass, and this was a big challenge in the program. We give people more protein, and protein was not calculated as percentage, but as gram per kilogram. And then more strength exercise, and especially after they eat the meal. So they eat the larger meal with higher protein, and then they immediately exercise so they can get benefit. And we measure their body composition, and it improved significantly in that scenario, which helped them to maintain that weight loss. I think the opportunity for remission, and I encourage everyone to take that opportunity as a kickoff by 1 month and see how it will go in 3 months and then in 1 year and beyond.
So it's important to continue to see these patients after this period and to see when the diabetes will come.
We actually keep them on CGM all the time. And they have instruction that at any time, time range go lower than 85%, they have to repeat 1 week or 2 weeks and then continue back. So it has a self gauge that can adjust and keep them maintained. And most people did that. Some of them did it 2 times, some of them did 1 time, and they are still maintaining the remission up to now.
Thank you.
Thank you very much. Dr. Tariq Al-Had, Hamad Medical Corporation from Qatar. Question to Professor Inas Khaltout. You have shown that among your cohort with the cardiovascular risk factors, those who are taking SGLT2 inhibitor do have actually significant sort of incidence of hypoglycemia. Have you looked into the cohort in terms of other confounding, especially those who are actually taking multiple drugs together? Because in our clinical experience, the SGLT2 inhibitor are quite actually insulin sensitizer. And this could be quite detrimental when you use it in such patients actually who are fasting during Ramadan. Have you looked into this in your sort of multiple regression analysis after correction for other factors?
So we are now analyzing other results and to look really in details in this result. So for this reason, we know that there is an increased risk with SGLT2 inhibitors, risk of hypoglycemia when SGLT2 inhibitors are associated with sulfonylurea or with insulin. For this reason, we advise a physician and people to take this medication 1 month or 2 weeks before Ramadan and to adjust sulfonylurea, which would reduce sulfonylurea and insulin. And then during Ramadan, we didn't see any increases of hypoglycemia for patients using SGLT2 inhibitors. But of course, with other people with sulfonylurea, and as we know, there is difference between sulfonylurea with the old generation and the new generation. For this reason, we recommend and we insist to use this medication before 1 month before Ramadan to make all adjustments to avoid any incidents like hypoglycemia.
Thank you.
So, of course, we will have more explanation in the paper. We are now writing the paper, and of course, perhaps we will have the answer for this question in our paper.
Thank you.
Dr. Osama, you have your hand up.
Oh, yes. I would like to ask Hani, this is a very interesting presentation. And, pro-PNP, we are not using it as often as we do. And I think your encouragement to do it is very important. But my question for you, a lot of our patients have left ventricular dysfunction, as you know, either systolic, diastolic, or combined. Do you currently recommend for those people to do echocardiography on a yearly basis or infrequently or just one time? What is your current recommendation for those people with diabetes?
Thank you very much. So I think the pathway that we're talking about is patients who are in the outpatient diabetes setting, not patients who are admitted to the hospital with acute heart failure. So if the NT-proBNP is elevated and or there's an ECG abnormality, our recommendation really is to, 1, intensify therapy. So it's fairly obvious you can use the SGLT2 inhibitor regardless of the ejection fraction, right? From the diabetes studies, from the heart failure, DELIVER, and the DECLARE studies from Emperor Preserved and Reduced. It doesn't matter if you're diabetic or not. It doesn't matter if your ejection fraction is normal or not. You have to be on an SGLT2 inhibitor. The other things that we would do is automatically add an ARB or an ACE inhibitor, because that's been fairly clear. Unfortunately, a lot of diabetic patients are being treated only with amlodipine for some reason, so we don't know why that is. So it should trigger, at the basic level, a change in the therapy. The second step is referral. We know that those patients would need to be referred to a cardiologist for further assessment. Now, for me, the ejection fraction is important for a different reason. If I need to add a patient to add a beta blocker, for example, with severe LV dysfunction, that's important. You don't use that in HFpEF. If a patient has severe LV dysfunction, we would need to do an ischemia evaluation and maybe even put in an ICD. So for the more advanced levels of therapy, an echo is needed, but for at least the diabetes clinic, the endocrinologist, diabetologist, primary care physician, simply the addition of 2 therapies has been shown to be life-saving. In fact, this strategy was seen in 2 studies, was the Pontiac study. And in the Pontiac study, that's exactly what happened. They just did an NT-proBNP, and based on that, therapies were changed. This resulted in an almost 50% reduction in mortality and morbidity. So for the general population of diabetic patients, this is why we're making this recommendation. And of course, additional referral to the cardiologist for more clear risk assessment. Now, we don't need to repeat the ejection fraction annually. This is kind of a myth. You only need to do that if the patient has severe ejection fraction abnormalities and we're trying to look for an indication for an ICD, or if a patient has improved ejection fraction. So this is something a little bit more specialized, and usually these patients are much more symptomatic and a lot worse off. The second thing is actually the utilization of GLP-1 receptor agonists, because that's new, right? So after the SELECT study and the STEP-HF study, we realized that GLP-1 receptor agonists, through its direct effect on, as you mentioned, intrahepatic fat, visceral fat, C-reactive protein, actually reduces new events, cardiovascular, and new heart failure events, which is something we never were able to predict. So again, it's telling us there's a lot of, what should I say, overlap between the cardiac and the metabolic disorders, and it should facilitate the utilization of guideline recommended therapies in a more efficient manner.
In the era of GLP receptor agonists, as you mentioned, and as we're talking about Ramadan, is there any benefit of Ramadan fasting or intermittent fasting in the absence of weight reduction? Because I personally believe, obviously, with the GLP, a lot of the benefit was from the weight reduction, because we've known from weight reduction, from bariatric surgery, that it reduces CRP, it reduces BNP, it reduces... So is there any benefit in the... And Dr. or Professor Osama, you mentioned this, but I'd like to ask this question again because I think it's important. If you do not get any weight reduction, is there any benefit?
That's actually a very, very good point. What we know, and I think this will be more popular in the coming months after a significant publication will come out from a consensus group. GLP-1 causes significant loss in muscle mass, significant loss. So out of the total weight loss, around 40% of the weight loss is from muscle mass. This is extremely dangerous for most patients with diabetes, since they lose around 8% of their muscle mass every 10 years from age 40 up. So from 40 to 70, they lose around 24% of their muscle mass. And then if you add additional loss of muscle mass, it will be a problem. Increased frailty, admission to hospitals, and also mortality in the same time. And put people at the risk for sarcopenic obesity. So we have to be very careful. If we start GLP-1 for anyone, we have to significantly increase amount of protein and strength exercise. If we don't do that, it would be a major drawback, because the third thing that when you are fasting, that your body will do is that break down fat storage and also muscle, also protein. So, and as you had seen in the intermittent fasting alone, there is some reduction in the lean muscle mass. So this can be accelerated as well. So anyone who's fasting Ramadan should have higher protein and more strength exercise to maintain their muscle mass.
If I were to make a comment, obviously we have a large number of studies over the last maybe 5-6 years on different GLP-1 receptor agonists in Ramadan. GLP-1 receptor agonist is a friendly drug for people who wish to fast. In fact, it makes the fasting quite easy. Yesterday, I presented the first data on the oral semaglutide in Ramadan, where there is a very significant improvement in glycemic control as well as weight reduction. And obviously, there's been a lot of other GLP-1 studies in Ramadan that has been ongoing, and it's with good benefit. And I entirely agree that obviously a person with weight loss, they would lose muscle. And the advice from Professor Osama Hamdi, of making sure that we advise our patients on resistance exercise is very important. However, I'm not really too worried about the protein restrictions, because in Ramadan, everybody is feasting at iftar and with plenty of protein intake. So specifically during that month wouldn't be a problem of protein intake, but perhaps that's an important point to understand to improve on the outcomes of GLP-1 receptor agonist treatment in Ramadan and out of Ramadan.
But Mohammed, protein intake without strength exercise will not help the muscles.
Yeah, I agree.
We need definitely after iftar, and I encourage people between iftar and Taraweeh to do some 20 minutes of exercise, strength exercise. It can be very simple, as some little weights or stretch band, or even squatting and standing up. Because people lose muscle from quadriceps, hamstring, gluteal muscles, and core muscles, and they need to do something to maintain them.
Agree.
You want to add something?
Go ahead, yes, please.
Yeah, please. Thank you. Regardless the change in the muscle mass from our professional studies on Ramadan fasting in healthy people, non-diabetic patients, we found that there is no significant reduction in the muscle mass actually. And there is very, very slight, less than 0.1% most of the studies. This is simply because we are practicing intermittent fasting, and there is no drastic reduction in the total caloric consumption during Ramadan. Apparently, some people say that we have overconsumption. No, we haven't overconsumption. Actually, we have lower consumption, sometimes the same, sometimes less than, and very few people, they have more than. I'm talking about systematic reviews and meta-analysis, not personal observations. Don't look for those who go with the Prophet. This is cannot be generalized. Not all the people who go into the Prophet. What I say, this should be considered once we're discussing fasting among non-patients. The other thing, yes, there is a beneficial effect of fasting Ramadan for healthy people, regardless of the weight loss. There is reduction in the inflammatory cytokines, interleukin 6, TNF-alpha, interleukin 1 beta. All these are improved, actually reduced by the observance of fasting as a result of the abstinence itself, regardless whether this abstinence ends with a significant weight reduction or not.
Thank you, thank you. Thank you for all your comments, and really thank you for all the participants and the discussion that we've had. Excellent final session. I'll leave it now to Muhammad. Saleh is going to come and provide a summary. Thank you.